Hello, this is Dr. Jeffrey Miller from Baltimore, Maryland. This is part 4 of a 5-part series on alveolar-focused orthodontics, visualization of limitations of orthodontic tooth movement through cone beam CT. My name is Jeffrey Miller. I graduated from Towson University, got my dental education at University of Maryland, my orthodontic certificate at State University of New York at Buffalo. My board certification in orthodontics in 1991. I've been in private practice for over 33 years. I'm a member of the Golden Circle of Excellence, and I speak on cone beam CT topics related to orthodontics. If we use cone beam CT to change the way we treatment plan and diagnose our cases, it only makes sense that the use of cone beam CT would change the way we evaluate our results when you compare to a pan and a ceph. I pulled this case directly off the internet. This is a case that was treated non-extraction using a certain bracket system that claims to have a physiological force that allows for expansion and bone modification as the tooth is expanded. If you would evaluate this case using cone beam CT versus Supplementary, I think you would come up with two completely different conclusions as to whether this was a successfully treated case or not. Here's the pre-treatment study models. This is the photograph, the clinical photos before and after. And here is the supplementary superimposition of pre and post treatment. This is another case. This is a case that is 5 years post active orthodontic treatment. He came in as a referral from his general dentist because she noticed some issues with the lower left lateral incisor as well as the lower right lateral incisor. What turned out was this young man, as he went away to college, started chewing on plastic water bottle caps. And those plastic water bottle caps cause some torquing issues associated with those teeth. I know there's reports in the literature that these Twistiflex wires sometimes unravel and cause odd torques on teeth. I don't believe this is the case here, and I'll explain why in a minute. Here's his virtual study models. This is the reconstructed Panorex from his cone beam CT. The Panorex, other than the third molars, looks completely normal. There doesn't appear to be any issue there at all. Well, what about the Supplementary Xray? Well, if you take a look at the incisors on the Supplementary Xray, they look fine. In case you're wondering why I'm taking these images open versus closed, supplementary standards say that the image should be taken with a bite and occlusion. Well, it's different when you're using a cone beam CT. You're looking at individual teeth and the bony support for those teeth. If the teeth are overlapping, it clouds the image. There's also software that you can upload the DICOM file produced by the cone beam CT where you can simulate treatment and you can see the resulting root and bone. And when you have the bite closed, that's a little more difficult to do. Here is his, when we first saw him in December of 2016. You can see the issues associated with both the right and left lateral incisors. Here is his 3D reconstruction, cone beam CT. Here is his mandible, and you can see how this root is just pushed out there. Here's a slice taken through about the top 1/3 of the root, and you can see here how this pulp chamber looks oval shaped, which indicates the tooth is flared out, where the left lateral incisor, the pulp chamber, is fairly normal looking. It's the entire tooth is pushed out of the arch. Here's tooth number 26. This is the lower right lateral incisor, and you see it had lingual root torque. And on tooth number 23, you see it has excess facial root torque. Now, I mentioned before that I don't believe this is created by the fixed retainer. This is, remember, 5 years post-active orthodontic treatment. If you notice, this patient still has plenty of alveolar process, which indicates to me that this is more of an acute problem. If it was a long-lasting problem, this lingual bone would have resorbed. Here is another case. This is a different case. This is a case a colleague sent me from Florida. This was an Invisalign treatment case, and you can see how these teeth were pushed past the limit of the cortical plate, but also notice how the alveolar process has resorbed. So now it makes it much more difficult to try to reposition this tooth back over the thickness of the bone. I'm sure the frenum has something to do with that as well, but if you compare it to this patient we're currently looking at, you can see the difference in the thickness of the alveolar process. Here we still have a fighting chance of maybe retorquing this tooth back into position. Because of his deep bite, we decided to use lingual appliances. These are custom appliances made by 3M, and we can order exactly how much torque we want on these teeth. I bypassed the centrals and the cuspids because I wanted to start with a rectangular wire. I wanted to get this thing going as quickly as possible. These forces should cancel each other out as they start to retorque those teeth. And here he is 3 months later. You can see it's looking a little bit better. Here's what he started with in December. Here he is in May. The left lateral incisor looks like it's back in bone, and the right one still seems like it has a little bit to go. In June, the next month, we put the rest of the brackets on and tried to get a little better alignment. And you can see here, you can see that that tooth went back into the bone. I did not take a follow-up cone beam CT. I will once treatment's completed, and it gives it some time for immature bone to fill in. You can see here's the root eminence. So what's the point? Why am I showing these two cases, and what do they have in common? Well, here's that tooth, the lateral with the strong root eminence. Take a look at these incisors here. From cuspid to cuspid, each one of these has a fairly strong root eminence. It's sometimes referred to as washboard gingiva. I would also suggest that if this lateral incisor position was universal on the cuspid to cuspid, it wouldn't even be noticed by the general dentist because every one of these roots would have looked like it was bulging out. Here's another case. You can see the prominence of these roots, and on this particular case there's tissue dehiscence associated with it. Talk about washboard gingiva. Washboard gingiva is really much different than washboard abs. I don't believe washboard gingiva is positive. Here you can see the root eminence. I believe that if it's orthodontically related, it has to do with the roots being torqued with disregard to the bone anatomy that supports those teeth. In other words, these roots have been pushed past the limit of the cortical plate, and in that case you get orthodontic dehiscence pattern. Insanity, doing the same thing over and over again and expecting a different result. That's from Albert Einstein. Thanks for listening. If you have any questions or comments, you can always email me at drmiller@orthodonticassoc.com. Thank you very much.